So for the next 10 to 15 minutes, I'll be talking on cardiovascular disease meets COPD, the role of beta blockers. Now, the crux of the matter for this duo of COPD and CVD is that both COPD and cardiovascular diseases are commonly associated and both require comprehensive treatment for optimizing the outcomes. The second issue is both share the common pathogenetic pathways of inflammation and neurohormonal activation, and the misconception commonly prevails that beta blockers are contraindicated COPD. No doubt, non-selective beta blockers are not appropriate, but selective beta blockers like bisoprolol can be very safely used, as I'll be showing the data. Selective beta blockers like bisoprolol rather must be used in COPD with concomitant cardiovascular disease, and its use is associated with decreased morbidity and mortality, and it does not aggravate COPD. Bisoprolol, as I'll be showing you the data, has no adverse effect on lung function, and interestingly, its use is associated with decreased COPD exacerbations and decrease in the all-cause mortality. And it also decreased SBA associated increase in the sudden cardiac death, which means short-acting beta agonists. And the highly selective beta blocker does not provide any effect like exacerbation of peripheral vascular disease, the metabolic effects, and the erectile dysfunction, which can be encountered with non-selective beta blockers like carvedilol. The prevalence and the mortality of COPD. COPD is the leading cause of morbidity and mortality worldwide, and the prevalence increases steeply with age, as you can see in this slide. COPD was projected to be the third leading cause of death in 2020, as you can see in this slide. It is number 3. And comorbidities are very frequent with COPD in the long run, because COPD treatment and the disease persists for a very long time. So you often have concomitant heart disease like CAD, heart failure, arrhythmias, hypertension, peripheral vascular disease, and others. In patients with mild to moderate COPD, the leading cause of morbidity and mortality is cardiovascular disease, and therefore special attention should be paid to cardiovascular disease. And when we look at the prevalence of cardiovascular disease as comorbidity in COPD, as you can see, heart failure is seen in 4 times, coronary disease 2 times, angina pectoris 2.5, myocardial infarction 2.5, and peripheral arterial disease 2.4, arrhythmias 2.4, and even stroke is more common with this. As we know, heart failure or ischemic heart disease and hypertension are common comorbid conditions. Attention should be paid for treatment of these comorbidities. And as already said, there is a scare among the physicians that the use of beta blocker in COPD for conditions like heart failure, CCS, hypertension, arrhythmia may aggravate COPD and add distress to the patient. It is true, if non-selective beta blockers are used for COPD, it may aggravate. But beta blockers, which are highly selective like bisoprolol, are very safe and do not aggravate COPD. And on the other hand, they improve survival, as I'll showing you the data. Now, when we have this duo of COPD and CVD, treatment of COPD improves lung function, but does not slow the progress to reduce mortality. Reducing mortality in patients with COPD should also focus on cardiovascular disease control rather than just treating COPD. And as you can see, major CVD guidelines do not consider beta blockers to be contraindicated in the COPD, particularly highly selective beta blockers, if patient has these comorbid conditions which I have told. So in patients with chronic heart failure, you can see the reluctance to use beta blockers contributes to approximately 7,800 deaths per year in the United Kingdom, a significant proportion of being patients with both CHF and COPD. There is often a reluctance to use beta blockers in patients with COPD, even if the patient has having a concomitant cardiovascular disease like heart failure, hypertension, arrhythmias, and other cardiovascular disease. As we see, only 14% of COPD patients were taking beta blockers for cardiovascular morbidity. 61% elderly post-MI patient less likely to be given beta blocker with a history of treated COPD or asthma. However, a trend of increased use of beta blocker in COPD, particularly the beta-1 selective like bisoprolol, could be noticed during the first decade of the millennium. Now, again, you can see that in total, the use of beta blockers after first MI was only 53% in COPD, as against 76% in non-COPD. The blue line, as you can, is non-COPD. Beta blockers are more often used, but there is now a trend even in COPD to have increased use of beta blockers. Now, this is again data from the Asian HF study in the context of underuse of beta blockers in patients of COPD with heart failure. As you can see, the uses of beta blockers was significantly lower in COPD, and obviously the heart rate would be higher in COPD group versus non-COPD. In contrast to the Japanese cohort, you can see usage of beta blocker was remarkably high and similar in COPD and non-COPD, and the use of cardioselective beta blockers was twofold higher in COPD group compared with the non-COPD. Clearly means that there is a lack of dissemination of the advantages of selective beta blockers. The other issue is that both COPD and cardiovascular disease have two things in common. There's neurohormonal activation in both, and there's also inflammation. And as you can see, beta blockers, they also have anti-inflammatory action as they decrease cytokines, and they also have neurohormonal blockade. So again, you can see here, both these conditions have both these factors in common. In beta blockers would not only help the cardiovascular disease, but will also help the COPD. And then we look at the causes of death in patients with COPD. You can see in patients with COPD, more than 50% of deaths are not due to COPD, but due to cardiovascular disease, heart failure, ischemic heart disease, hypertension, and so on. And this shows the distribution of the beta-1 receptors and the beta-2 receptors. You can see beta-1 receptors, they are present in the heart. They decrease heart rate, they decrease contractility, they also act on the kidneys, decrease resin. But if you have a beta blocker with BT receptor blockade also, you can see they will produce panoply of side effects due to blockade of the beta-2 receptors, like they will aggravate COPD, they will also produce erectile dysfunction, and they have also various metabolic side effects. Now, this clearly shows that bisoprolol has a very high beta-1 selectivity. You can 19.6-fold higher than the beta-2 receptor. So if you use a highly selective beta blocker like bisoprolol, you will be targeting only beta-1 receptors, and you will not have the side effect of beta-2 receptor blockers. The other issue, do selective beta blockers adversely affect lung function, which is a common misconception? The answer is no. And this clearly shows that when you use selective beta blockers like bisoprolol, this is the airways resistance. You can see hardly any change, no increase, slightly decrease when you are using bisoprolol. On the other hand, if you are using atenolol, there may be some increase. So the notion which percolates that beta blockers should not be used in COPD. Beta blockers are contraindicated, is not appropriate. You can certainly use very selective beta blockers like bisoprolol, and the other advantage I'll be showing you shortly. Now, bisoprolol has only minimum effect on the airways resistant in asthmatic patients. This is placebo. You can see hardly any change in the airways resistance. But if you use atenolol, the airways resistance would increase. Bisoprolol, as you can see, compared to carvedilol, the effect on the FEV1, you can see carvedilol, but not bisoprolol reduce FEV1, FEV1, but carvedilol also causes more pulmonary side effects. So carvedilol, which is a drug for heart failure, is not appropriate when the patient has COPD. It is not a selective beta blocker, so you will have side effect of increasing airways resistance. And this again shows the advantages of bisoprolol. You can see in hypertension, other cardiovascular disease, bisoprolol showed an insignificant trend to improve respiratory function after 12 weeks of treatment. Metoprolol showed an insignificant trend to deteriorate respiratory function, and bisoprolol reduced dyspnea intensity level slightly more than bisoprolol. And another study, you can see bisoprolol demonstrated no significant changes in the respiratory function, peak volume expiration velocity. Atenolol and metoprolol cause a significant reduction in peak volume expiration, and the quality of life improved with bisoprolol but remained unchanged with atenolol and metoprolol. And this again shows that bisoprolol still shows beta-1 selectivity, so that if you are using bronchodilators in beta, that is the beta-2 agonist salbutamol, its action is still preserved. And this again shows the effect of carvedilol, bisoprolol, and nebivolol on the DLCO, which is a pulmonary function test. Carvedilol decreases DLCO, whereas nebivolol and bisoprolol has no effect, carvedilol decreases. So the other issue is, what is the effect of beta blockers on COPD exacerbation and all-cause mortality? You can see here, beta blockers do not increase the risk of exacerbation. The evidence suggests that beta blockers, particularly bisoprolol, they decrease COPD exacerbation. So if you are using beta blockers like bisoprolol, there is no exacerbation of COPD. On the other hand, there is less exacerbation of COPD. And very interestingly, the all-cause mortality is also decreased 14 to 61% in various studies. So if you use selective beta blockers, there's no aggravation of COPD. You also decrease the all-cause mortality. And here you can see the risk of patient treated continuously for 6 months with beta blockers compared to those who are on other. The risk reduction in all-cause mortality decreased by 44%, and the risk reduction of COPD hospitalization decreased 20%. The mortality of COPD patient hospitalized for MI compared to patient discharged with a beta blocker and those discharged without a beta blocker, as you can see here. Beta blockers before and the time of MI was associated with improved survival. Patient with COPD discharged with beta blocker after MI has a lower all-cause mortality. So again, showing the benefits of selectivity. What is the effect on SBA, that is short-acting beta-1 agonist, on the sudden cardiac death? All of us know beta-1 stimulants like salbutamol, they increase sudden cardiac death, as you can see, COPD alone, and when you use SBA, the sudden cardiac death is increased. But if you use bisoprolol, the sudden cardiac death is decreased. So that is another advantage. And this is again showing that when we compare the effect on all-cause mortality, whether the patient receives beta blockers or no beta blocker, green is no beta blocker, and this dark green is beta blocker, there's decrease in all-cause mortality. And if you compare the blue one, carvedilol, with the red bisoprolol, all-cause death in CHF COPD exacerbations were decreased markedly, roughly 2 times or little more. And so also CHF and COPD aggravation, if you use bisoprolol, it is decreased almost 3 times. So what is the take-home message? One number message is COPD and CVD are rampant in the Asian Pacific countries, and this duo has a high morbidity and mortality. Beta blockers are highly underutilized in this DO due to fear of precipitation of COPD. But the truth is, highly selective beta blockers like bisoprolol do not adversely affect lung functions. Use of bisoprolol in this DO decreases mortality, reduces the risk of sudden cardiac death and COPD hospitalization. Thank you very much. Most of us, rather many cardiologists and physicians, do use DO beta blockers like bisoprolol, nebivolol in the treatment of hypertension. So what is your opinion? Will beta blockers appear in the hypertension guidelines in future? Because when they were discarded, it was atenolol and the data based on atenolol.
Definitely, sir. In young patient, when there the sympathetic overactivity is there, definitely the selective and beta blocker like bisoprolol is a drug of choice, because as we know, the lot of trials and lot of things that shows that the whatever the side effect was there initially with atenolol is no more with this selective beta blocker. So in younger patient, definitely it can be used as a first line of drug. But in older patient, I think still the ARBs and SE inhibitor and calcium channel blocker and diuretic are the drug of choice. The other field where we can use this beta blocker, and we are using, like angina, post-MI angina or heart failure patient. So definitely beta blocker has its role, definitely.
All of us would agree that bisoprolol is a good antihypertensive, nebivolol is a good antihypertensive, and many cardiologists, physicians do use it. But the problem with the guidelines is they want a trial before getting included in the guidelines. And I don't think any pharma would conduct a trial in young hypertensive where this is the drug of choice, because all trials want events, and young hypertensive will not have events for many years. It is not the drug of choice in elderly, as you said, so getting a trial of beta blockers in elderly is not meaningful. So that may be one of the hindrances, because guidelines do not change the recommendation unless they have a trial. And when we are treating hypertension, any young hypertensive who has an increased heart rate and whose pulse pressure is high is a good candidate for beta blockers. And we have time and again, particularly the IT workers who do not sleep in time, take their dinner at midnight, and are always busy, do not take exercise. They respond very well to beta blockers. AC inhibitors, calcium channel given to them, they don't respond. Just a small dose of beta blocker, they feel well and they respond. So young hypertensive, you must check that there's increased sympathetic tone. Beta blockers are the drug of choice, bisoprolol particularly, because the long-term compliance with bisoprolol would be maximum, because the side effects are not there, as you have pointed out. Nebivolol, the problem is the viability is highly variable. Some patients have rapid metabolizers, some patients have slow metabolizers. So the pharmacokinetic variability is also very variable. Whereas bisoprolol, the pharmacokinetic variability is also best compared to metoprolol and carb. So that is other reason, because nebivolol, this problem, you do not know how much drug is in the blood, whether you are a rapid metabolizer, whether you are a slow metabolizer, cannot be tested by simple test. So that is the other reasons. Any questions from the audience? One question from the audience is nocturnal heart rate is needed to be addressed than the morning heart rate to avoid CV events? Dr. Somani, your viewpoint.
I don't think, if you go through the test and investigations, and if you come to know that the nocturnal heart rate is at a very higher rate, than in spite of taking a beta blocker in the morning, you can take in the evening time. That is one of the things. But otherwise, nocturnal heart rate and blood pressure, as we all know, it is always on the lower side. They are never be on a higher side. So it's very rare that the nocturnal heart rate is on a higher side and the blood pressure is on a higher side. If it is there, then the most, I think, acceptable thing is that presently, I think the hypertension guideline and a lot of people, they says that hypertensive medication should be taken in the evening or in the night time. So that will take care of your night and the early morning search of the blood pressure. So that is the best way. Otherwise, I don't think there will be any need.
See, there is a small group of, usually, as you said, blood pressure falls in the night, heart rate all falls in the night. There's a small subset of patient who shows reverse dipping, which means
reverse
the blood
dipping
pressure rises in the night and the heart rate may also rise because of increased sympathetic activity.
Yes.
Perhaps he is talking about that subset of patients And if that be the state of affairs on ambulatory monitoring, he can take the blood pressure, he can take beta blockers at night, as
Yeah,
you suggested.
that's what I said.
There is one more question. Is it that the patient with CCS incidence of acute events have increased due to COVID? That is not related to the
I don't think, because a lot of things are nowadays people are correlating with the COVID, but there is no definite evidence or definite proof that you can correlate it with COVID. But definitely COVID has caused a lot of endothelial dysfunction, endothelial disease, lot of thromboembolic phenomena. But how we can correlate with all these in present scenario, it's difficult to say. We have seen a lot of cardiac patients during COVID time, cardiomyopathy also, MI also, pulmonary embolism also. But, it's very difficult to correlate the things.
So the big message from the symposia are: number one, COPD and cardiovascular disease both commonly coexist.
Yeah.
If a patient of COPD has a cardiovascular disease, which is hypertension, heart failure, arrhythmias like atrial fibrillation and even ventricular arrhythmias, and coronary artery disease, beta blockers must be used, particularly bisoprolol. And the use of bisoprolol, even in the presence of COPD, does not aggravate COPD, as we have discussed, and it decreases all-cause mortality, decreases aggravation of COPD, and also decreases death related to the use of beta stimulants. So the big message is, all patients of COPD where cardiovascular disease is concomitant, beta blockers should be used, and the preference falls on bisoprolol because this is a highly cardioselective. Carvedilol is not highly selective, it is a non-selective beta blocker, and metoprolol, the selectivity is less than bisoprolol. So long-term compliance of bisoprolol will be good because of failure of blocking the beta-2 receptor. So that is the big message from this discussion. Over to the organizers if they have any questions or comments.